Good afternoon, everyone. Thank you so much for joining us for today's virtual public forum, Opportunities for Innovation in HPV-Related Disease. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research. SWHR is the thought leader in promoting research on sex as a biological variable and improving women's health through science, policy, and education. We are extremely pleased today to have three distinguished panelists joining us. We have Kate Weissman, a cervical cancer survivor, Dr. Mona Soraya, medical officer and team lead at the CDC's Division of Cancer Prevention and Control's Epidemiology and Applied Research Branch, and Dr. Mark Einstein, gynecologic oncologist at Rutgers Cancer Institute of New Jersey at University Hospital. I'd also like to thank the sponsor of today's virtual public forum, Inovio. If you are also tweeting about the event, which we are doing live, you can use the hashtag SWHR_TalksHPV. Human papillomavirus, or HPV, is the most common sexually transmitted infection, and it can cause a variety of cancers, including cervical, anal, vaginal, vulvar, and oropharyngeal. Unfortunately, due to the multizonal nature of HPV-associated precancers and cancers, there remain gaps in prevention, screening, and research. Women also, frankly, deserve better than the limited and invasive treatment options that are currently available. Back in June, SWHR hosted a multidisciplinary roundtable on this topic, which featured a variety of experts and patient advocates. One of those patient voices was Michelle Longabaugh. Michelle was a nurse, a wife, and a mother. She was an anal cancer survivor who dedicated herself to reducing the stigma of HPV-associated disease, specifically anal cancer. We were all extremely shocked and saddened to hear that just 1 week after sharing her story with us, Michelle passed away. She had shared with us her struggle with her diagnosis, and she had noted that anal cancer victims are the invisible victims of HPV, especially women. Although anal cancer is rare, 66% of cases occur in women, and disease incidence is rising, especially in older white and Black women, as well as younger Black men. Again, anal cancer is not the only HPV-associated disease. You'll hear today a lot about cervical cancer because that's the one that we know the most about, further highlighting the gaps and areas of need in this space. HPV-associated precancers and cancers are preventable and with available vaccines, and in the absence of that could be better monitored, managed, and treated with greater innovation. Our panelists today are going to discuss the innovations in research, clinical practice, policy, and education that are needed to improve health outcomes for women with HPV-associated cancers and precancers. And with that, I would like to introduce Kate Weissman to share her story as a cervical cancer survivor. Kate, I'm going to turn the reins over to you to share your presentation, and thank you again for joining us.
Hi, everybody. Thank you so much for having me here today, and I'm really honored to speak alongside these incredible doctors who are really moving the needle for women like me. So it's really an honor to be here with you today. So as has been said, my name is Kate Weissman, and I am a cervical cancer survivor. I start my presentation with this slide. It's a photo of my husband and I in Maine, the weekend before I was diagnosed. And if you speak to any cancer survivor or patient, they'll tell you there was life before cancer, and then there was life for those of us who are lucky after. Your world cracks in half when that cancer diagnosis comes, not just for you, but of course for your family. I knew that I had HPV. I had learned that I had HPV 2 years before my diagnosis. My doctor and I stayed on top of my pap smears and all of those checkups. But unfortunately, the cancer was essentially hiding itself, and it took to be at stage 2B really before they found it. And I got to that point because I went off the birth control pill in preparation for another surgery, and all of these symptoms of the birth control pill I'd almost been hiding, irregular bleeding, etc., started to come through. And so we really started to increase my screenings. And then a colposcopy in October of 2015 showed that I had stage 2B cervical cancer that had gotten into one of my lymph nodes. So instead of doing a hysterectomy, we decided to do radiation and chemotherapy. I went through the Dana-Farber. I started my treatment in November, and it was really brutal. It was 30 rounds of radiation. 5 of those rounds were internal, called brachytherapy, where essentially I was put under general anesthesia, and a rod was inserted in my vagina to administer the radiation that way. And I also supplemented that with 6 rounds of chemotherapy, a drug called cisplatin. And the side effects were really intense. A lot of nausea, a lot of fatigue, weight loss. And the radiation it kind of turned my insides out, I always said. And the internal radiation caused a lot of scar tissue that I'm still dealing with to this day. I share this picture as well because it takes a village, if you're lucky to have one, to get yourself through cancer treatments. This is a photo I took of my mom and my husband while I was in my chemo chair. My dad was probably off doing the 7 millionth errand. We had him running that day. And, it really does take a village. It impacts a lot of people around you. And I also pause to say people who have HPV-related cancers deal with an enormous amount of guilt and shame for the cancer that they have. They feel like some decision they made along the way caused this pain among themselves and their family. So there's a really important demographic of people that we need to focus on their mental health as it relates to cancer as well, because there is a lot of guilt and shame that come with HPV-related cancers and a ton of stigma related to it as well. I was lucky to have a family that was understanding and accepting of what was going on, but I know a lot of women have had families turn their backs on them because they've been diagnosed with an HPV-related cancer. I can say that my treatment for that time we thought worked. I went back to work. I was sent an embarrassing display of balloons by my parents to celebrate returning to work. But unfortunately, a scan 3 months after my treatment wrapped showed that the cancer had in fact spread to my para-aortic lymph nodes. So I immediately went through a procedure to remove those lymph nodes. And then I was transferred to Mass General Hospital to go through proton beam radiation therapy, a different type of radiation that would be a little bit more targeted, along with chemotherapy. Unfortunately, my insurance company did not see that this would be a measure to cure me, so they refused to cover the treatment. And after 7 rounds of appeals, my parents had to pay for this treatment out of pocket for about $100,000 for me to get this treatment. And I'm just extremely lucky that was even an option for me. It's not for many other women. But I went through the 25 rounds of radiation, 5 more rounds of chemotherapy, and things were looking positive. After completed those rounds, they actually sent me through another regimen of chemotherapy called Outback chemotherapy, 6 more rounds of that. And that caused me to lose my hair. I have to say my husband and I had to keep a sense of humor throughout this whole process. As this slide shows, this was the night that we shaved my head because we knew that we were working towards a cure. And the prognosis at that point was really positive. And I can say that we were really happy to say that the cancer was gone after this treatment. And I also share this photo of my dog and I because, again, it takes a village to get cancer survivors and patients through their journey. October 3rd, 2016, this was my last day of chemotherapy and treatment, and I was done after this. And I just always give a shout out to, this is a very small sampling of my doctors, my team that kept me here. But I was really dealing with getting back to life. This is a photo of my husband and I at a wedding right after treatment ended, dealing with getting back to life, being so thrilled I was still here, but also an enormous amount of guilt and shame that I mentioned earlier hit me like a tidal wave for what I just put my family through. And also I was dealing with survivor's guilt, and the depression and anxiety of what I had just gone through, the trauma, was really something that had to work through. I'm very lucky to say I had access to mental health professionals to get me through there. But I think it's also really important that people realize cancer survivors, you know, there's a time period after treatment and well after that they need a lot of emotional and psychological help as well. So it's always something that I want to make sure that I explain. After the dust settled, if you will, and I was a couple years out of treatment, I found an organization called SWHR. And SWHR, I can say, single-handedly changed my life. It is for the empowerment and education of women and communities about cervical cancer. And for the first time in my life, I was able to meet other women who had been through what I had been through in different ways. We all had different surgeries, treatments, everything, but we could all come down to say, you know, this is an experience that we had, a shared experience that we had, and how can we prevent this from happening for women like us moving forward. This is also where I was able to share my guilt and my shame with other women, where I learned about even more so the stigma of HPV-related cancers. It's where I became more educated about the fact that women of color are disproportionately, the outcomes are more negative for women of color in this disease than any other, that divorce rates are extremely high for people with this disease. This is where I really started to get my tool belt and learn what I needed to do to advance this for women in the future. And I also became involved with the American Cancer Society Cancer Action Network. And with this group, I lobby in DC or in the State House in Massachusetts for different bills that will move the needle and really help women. For example, the Jeanette Acosta Invest in Women's Health Act I lobbied for last year that would increase access for treatment and screenings for women of color. I recently just lobbied for a bill called the Henrietta Lacks Cancer Research Enhancement Act that would decrease the barriers of entry for everyone to clinical trials, which disproportionately exclude people of color, people in rural America, and lower income Americans. And doing that really allows me to turn my pain into my power and help women that went through what I went through. I would just conclude also by saying that along this way, I've learned there is a severe lack of education about HPV, how it's transmitted, about the HPV vaccination, and how that it can be dangerous when in fact that's completely unfounded. And we really have a long way to go as a society in educating people about the HPV vaccination and how effective it can be. So I just really appreciate everybody being here today to learn about this, because this is a disease that we can end in our lifetime if we spread enough awareness about it and end it so women like me don't have to suffer anymore.
Thank you so much, Kate. We so appreciate your willingness to share your story. I think that between that and also your advocacy on behalf of not only yourself but countless others is really important. And I know it can be difficult, but we very much appreciate that. So with that, I'd like to invite Dr. Soraya to share her presentation. I'm delighted to welcome you to present on the current screening guidelines and CDC's work in this space.
Great. Thank you so much for this invitation. It's really an honor to be speaking, and a hard act to follow after Katie. So I don't have any conflicts of interest. Before I started, I just wanted to acknowledge that, there are several HPV-associated cancer cases in the United States, not just cervical, although the focus of my talk will be cervical. Cervical cancer is the most common cancer among females, followed by anal, vulvar, oropharyngeal, and vaginal cancers. And among males, oropharyngeal cancer is the most common compared to anal and penile cancers. And although I'm not showing trends today, cervical cancer rates are definitely going down. Anal cancers and vulvar cancers are going up among women, and among male, oropharyngeal cancers and anal cancers are going up. Worldwide, cervical cancer exists. There's more than 500,000 cervical cancer cases diagnosed a year and more than 300,000 deaths. It's the fourth most common cancer worldwide and the 13th most common cancer in the United States, with almost 13,000 new cases and 4,000 deaths occurring every year. It's important that we don't forget about precancers. It's estimated that there was approximately 200,000 high-grade cervical lesions every year, and that presents a significant number of burden for everyone, and especially anxiety among women. This is a slide that looks at trends for cervical cancer since the PAP test. Since the PAP test was introduced in 1950s, but we didn't have cancer registries till the 1970s, you can see that rates of cervical cancer have been going down. The new cases are in blue, and the deaths are in purple. And it appears like we have stagnated in the last few years, but I'm going to go into a little bit more detail later on among the youngest age group. This slide basically looks at disparities in the United States. It's really important to acknowledge that this is really a disease that really is a highlight of poverty here in the United States. Black and Hispanic women have much higher rates of cervical cancer. As you can see on the graph on the right, women living in rural areas are at highest, get more cervical cancer, but also in the right hand, they also have higher rates of mortality, and women with lower socioeconomic status. And it's important to remember that in most of our data, which still continues to be true, is that women who do get cervical cancer, almost half of them are women who have never been screened or not screened in the past 5 years. So we always say the best test is the one that gets done, and it's really important to keep in mind those women who don't get screened and why that is. This is a slide on HPV vaccine recommendations, and I just wanted to review the data. In 2006, there were recommendations to routinely vaccinate with 3 doses, girls 11 to 12 with catch-up through 26, and then 3 doses in 2011 for males 11 to 12, and their catch-up was through age 21. And then in 2015, Gardasil had the 9-valent vaccine, where before we had 2 vaccines, and now we only have 1 vaccine here in the United States. It's the Gardasil. In 2016, there were recommendations to give 2 doses if the vaccine was started before age 15. And then just recently in 2019, there were recommendations for catch-up of the HPV vaccination through age 26, and for ages 27 to 45, shared clinical decision-making. The recommendations for the HPV vaccine, this slide basically looks at several different vaccines that are recommended during adolescence. And what I wanted to highlight is how the blue and the red, which are the Tdap, tetanus, and meningitis, are basically at a much higher rate. Their vaccine coverage is a much higher rate among adolescents than the orange line. The orange line is basically at least 1 dose of HPV vaccine, which is around 68%, 60%. And then nowadays, when at CDC, we look at up-to-date vaccine that takes into consideration 2 doses versus 3 doses. And so this data point really sort of highlights that the children are getting vaccinated, but they're not necessarily getting vaccinated with the HPV vaccine. And we think that a lot of that has to do with provider recommendations for this particular vaccine. This slide just looks at MAP through the United States in terms of at least 1 dose of HPV vaccine, and you can see there's substantial heterogeneity of the coverage, with 89% highest rate in Rhode Island compared to 52% in Mississippi. And this slide basically shows that we see differences in coverage by urban and rural status over time. The coverage has consistently been lower in rural communities. However, despite the lower coverage, we see that coverage is increasing in rural areas at the same rate as it is for urban areas. So some of the lessons we've learned for HPV vaccine are that provider levels can be effective, but they're difficult to bring to scale. it's also important to remember that there are just disparities, and we really need to work with coalition building at the national, state, and local level to address some of the HPV vaccine issues at the provider level and address parental concerns. And major focus on systems level interventions are what we're focusing on lately at the state level as well as the national level. And that means looking at and inviting major payers and health systems at the table, including Medicaid managed care organizations. What about cervical cancer screening? Wanted to just let you know that the slide shows current guidelines for the United States, and I'm not going to go into detail about these guidelines, but from 2012 to 2018, guidelines were generally consistent. They diverged a little as to when to start. And we sort of have a slightly divergence, but basically one can start screening at age 21. American Cancer Society has come out with new guidelines to start at age 25. Generally stop screening at age 65, but it's really important to keep in mind that women have to be adequately screened before they get stopped, and sometimes that's not taken into consideration. And also screening, what one can screen with, they can screen with a PAP every 3 years, a PAP and an HPV every 5 years for women 30 and older, and an HPV alone every 5 years for women 30 years of age and older. Some of the guidelines recommend one test over the other. And I think it's important to know that in general, these guidelines are moving towards an HPV-based strategy. So, you know, the PAP test may not play as an important role in, especially in the American Cancer Societies moving forward. When we look at national surveys, this is the only way we really have to look at what the level of screening is in the United States, because we don't have a registry for screening across the United States. We see that up-to-date screening, this is with the PAP test, has hovered around 80%. And only recently have they started asking about HPV testing. But even with that, the up-to-date cervical cancer screening is around 80%. And so that still means, or 85%, that still means that approximately 15% of women are reporting that they're never have been screened. This is another survey called the Behavioral Risk Factor Survey that can look at state. And in this data, it shows that approximately 82% of women have had recent screening, consistent with that other survey. But it's actually able to go into a little bit more detail and say that 40% of women report that they've been co-tested. I think that has a lot to do, we're not sure, that's not really consistent with some of the anecdotal data we hear from clinicians that co-testing is the predominant strategy. And this could have a lot to do with the fact that this is a self-reported survey and women don't really know what they're getting screened for. Is it a PAP, pelvic, STD, HPV? It all means, it's all like one jumbled up test that they really are not aware of. And it could be because providers are not necessarily informing them of what they're getting screened, or it's a new concept. So some of the lessons we've learned to improve cervical cancer screening are that consistent guidelines across organizations are important, and guidelines do take a lot of time to actually, be practiced. People say around 10 years. So when guidelines change a lot, it does become a little bit difficult. It's also important to acknowledge that pathologists play a critical role in promoting newer technologies. A laboratory may not offer all of these newer technologies. Both overscreening and underscreening occurs here in the United States. And some of these systems measures that we have from the National Center of Quality Assurance called HEDIS measures, as well as uniform data systems and the CMS measures are all focused on screening, and not necessarily many measures that are focused on follow-up and management. And then again, as I mentioned before, information systems are critical. We may have a system for screening, but then when a woman is referred, we don't have that information system available to make sure that she gets follow-up of her abnormal result in a timely manner. What about HPV vaccine? I'm quickly going to go through this. We know that HPV vaccine is very important and can prevent a lot of outcomes. We already have data from several countries that HPV infection has gone down, genital warts have gone down, cervical precancers have gone down, and just recently in the last couple of weeks, we've had paper come out from Sweden in the New England Journal of Medicine, which is a game changer in my opinion, that shows that cervical cancer has gone down. Here's the paper and the reference. And basically it shows that HPV vaccines reduce the risk of invasive cancer, not just pre-cancer, by 88% if a girl or person was vaccinated before age 17, and by 53% if they were vaccinated between the ages of 17 to 30. What do we see in the United States? We're just starting to look at these data, and this was recently published, when we see that rates all across all ages have gone down. But when you look at the youngest age group that may have been vaccinated, such as a 15 to 20 or 21 to 24, you can see that there's only 18 cancers here in the United States in the 15 to 20-year-old, and 71 cancers in the 21 to 24-year-old. And this is a graph that looks at it broken down by the cell type. And you can see that the dotted lines are what would have happened before the HPV vaccine was introduced, and what is currently happening in the solid lines by those in black, which is the squamous cell cancers, and those in the gray, which is the glandular cells. And it's really exciting to see here in the first slide that you see that after 2012, 2013, the rates of, and these are small numbers, but only in the United States do we even have such small numbers, because we're such a large country and have a good cancer registries. We're seeing a marked decrease in squamous cell carcinomas. And that kind of decrease, we're starting to see a little bit of that in the 21 to 24-year-olds, but not necessarily in this should be 25 to 29-year-olds. So this is really exciting data, but of course we don't have vaccine information. And I just wanted to end with that good news as we start an initiative for cervical cancer elimination worldwide next week on November 17th. Thank you so much.
Thank you so much. I think there's a lot here for us to be thinking about for the future. Obviously looking at, the cervical cancer rates and sort of aligned with, HPV vaccines, et cetera. So thank you so much for that. Dr. Einstein is going to discuss the changing landscape of cervical cancer prevention and talk through some of the clinician education and innovation aspects of this space. So thank you so much for being here.
Well, thank you very much for having me, and thank you all for coming and joining us today. And I'll try to keep my talk brief so that we give you all time to ask some questions, and we could go in the directions that you want to go with regards to questions regarding screening or management or treatment of some of the difficult aspects of this disease. In terms of my disclosures, I work with a lot of companies. We design clinical trials. I receive no money for anything that I do with any industry. And I also am the lead PI of a number of trials from companies within this space, including Inovio, but I am not talking about the Inovio product in this talk, but I am the lead PI of their phase 3 trial. And I serve a number of other roles other than my clinical roles, which are unpaid positions. I want to build on what Dr. Soraya was talking about, where there's a shift in a lot of the screening strategies that have happened. And what we have today in 2020 is very different than when all we had was a Pap test. And a Pap test has done wonders in the United States in managing and keeping cervical cancer in check. Cervical cancer used to be the #1 cancer killer of women in the United States in the early 1900s. And until there were a Pap test, now it doesn't really even make the top 10. But because of new innovations like identifying the role of HPV in all of cervical cancer and using very specific tests to identify HPV, we can get a much better predictive nature of somebody's risk for developing cervical cancer by doing HPV testing. So the strong recommendations that the American Cancer Society has recently put out actually builds on prior work that has shown that a negative HPV test is a very, very strong predictive marker for someone not getting a cancer. And this is one of many trials that have basically shown that if we just do a Pap today, that individual's risk is much higher of getting cervical cancer in 1, 2, 3 years later than if we do an HPV-based strategy, which is why we're seeing this shift to HPV-based strategies. And we're going even further now with some new innovations with things like self-sampling, and this is something that has been already adopted in certain areas like Western Europe. Many countries in Western Europe are doing it. Self-sampling is becoming pretty common in areas in sub-Saharan Africa and Latin America, and it is something that is being taken up. Let's face it, our pandemic has really opened our eyes to what happens to preventative medicine when things like a pandemic occur. And so it's kind of escalated the need for being able to do things at home, including screening. And there are like low literacy pictures of showing individuals how to do self-sampling. And in some areas in sub-Saharan Africa, this is life-saving. And all we need is a little bit to be able to actually test for HPV. And I think that this is a big innovation that might, that needs some further testing in the United States to eventually be part of an extension of screening. As Dr. Stry had said, we want screening to happen. Any screening is good screening. So, this might be an extension, especially for vulnerable populations that can't come in, or people that have poor access, even in the United States. All of these guidelines, as Dr. Stry had mentioned, it takes a long time. These are not things that happen overnight, whether they be screening guidelines or what do we do when we have these abnormalities. And we have to balance that care with simplicity. And sometimes, we do have good data to back up more complex things, but we have to achieve that balance. And, as a provider and as somebody who teaches other providers how to do things right, the more complex we get it, the less likely they will be adopted in real time. As Dr. Stry says, it takes a while because this stuff gets hardwired in doctors' heads. And then all of a sudden you get a guideline change and it takes them a while to learn it. And there are ways that we keep up and we maintain our education, but we have to also maintain that simplicity. So unless there's really any compelling reasons, we've stuck with a lot of the same sort of intervals of follow-up with some of the surveillance guidelines that are coming out. And when I talk about surveillance, I'm talking about people that have some sort of abnormalities, whether they be an abnormality of an HPV test or an abnormality of a Pap test or a combination thereof, or they have other high-risk features like having had like a prior treatment for precancerous lesions, or if they've had a prior abnormal Pap and a prior abnormal colposcopy. As Kate had mentioned, that was a colposcopy that led her to her diagnosis of cervical cancer. So these are things that we try to integrate into the regular and routine clinical management. But now, in addition to HPV and cytology, there's other innovative tests that are being looked at for screening. And as new screening tests come in, there's going to have to be changes in how these get adopted in real time. And we know there's a lot of automated cytology versions that are already occurring. But then there's even more molecular things. We've had an explosion of molecular technologies over the last decade, and we can make them very cheap. There are things like methylation and other things that we can do now for actually relatively cheap and relatively high throughput that don't have a qualitative nature to it or require what are highly educated and wonderful pathologists to do. So this could be very helpful in areas that have low human resources, low technical human resources, like in low and middle income countries. Also, like utilizing technology like automated visual inspection of the cervix. Actually, we're working on trials using face recognition technology to actually pick up precancerous lesions that far improve like what my eyes can see through a scope. And these are things, these are coming along very quickly. So using new tech to be able to do this. And then also other molecular techniques that are all being tested right now that will all be very innovative to be very efficient at picking up the people that are most at risk of actually having something that is clinically relevant now or in the very near future. And then they get stratified at risk levels. Part of this is based on their history, and part of it is based on the host of tests that they get, a Pap, HPV, even the type of genotype of HPV that they have actually goes into stratifying their risk. And the people that are most at risk, we say, hey, you need treatment like right away, okay? Whereas the people at least risk, or the people that we have the highest sense that they have a very low likelihood of getting cancer or having cancer or precancer now or in the very near future, we could actually extend the time before we have to actually see them again. So for the lowest risk women, we don't have to do more of these procedures, which actually can cause harm, all right, doing a lot of these procedures, all right? As somebody who does colposcopy, as someone who considers themselves as an expert colposcopist, expert colposcopy can be harmful, okay? Especially the more that we do. All right, but then it's also like weaving in how this gets interpreted by clinicians, and I'm happy to discuss this more, but you know, when we have these very dense guidelines and clinicians see these, they're almost like textbooks of guidelines and with like different algorithms and everything, and that could be very complex. But there's evidence-based approaches to that learning that people could understand just the broader concepts and then utilize tools like apps or embedded medical record tools or web-based clinical decision-making tools to sort of help them to monitor, so they don't have to like memorize all this stuff. I mean, when I started my career, you know, the person who memorized the most seemed to be the smartest in the room. Now the person that adapts those technologies the quickest is the smartest person in the room, and that's what we need to be working ourselves to. So getting more of these tools for the everyday clinician so that they'll be more apt to change their practices and adapt their guidelines will help to prevent missed opportunities, okay? And then we have continued education. All clinicians have lifelong learning now. We have what we call maintenance of certification. If you're board certified, there is a path of continued certification that happens, and things like these guidelines and updates and screening are part of that lifelong learning and something that is shared amongst all specialties that have direct primary care aspects to them. So I'm going to stop now. I know I gave some broad aspects, but I'd love to hear what your questions are, and maybe we could sort of have some interactive conversation through either chat or live.
Great, thank you so much. We do have a couple of questions coming in, and there's a few themes, obviously, that I've been thinking about sort of as we're listening to all of you. And I wanted to actually start with something that I know, Mona, you have answered this in the question and answer, but I want to see sort of what everyone's thoughts are, if they have any additional thoughts, and make sure that the audience gets the benefit of it. But there was the question of, is the HPV vaccine available for adults that haven't tested positive for HPV? I've found it very difficult to find a way for patients that are interested in getting the vaccine to purchase it out of pocket or find an entity to administer it. And I bring this up because it was one of the things that did emerge a little bit, right? So if we're looking at sort of the folks who maybe might have been quote unquote lost or had been older when the vaccine originally came out and we're looking at new clinical guidelines, they may have been missed in some way. And so the question, and we did see it in your slide, Mona, about shared clinical decision making, but I also wonder if there's sort of advice on for folks who might be interested in obtaining that vaccine as an adult.
So, I mean, I could speak to this as somebody who has those shared decision-making discussions with women, and you know, this is shared decision-making because, as the question was very specific, that they've had a diagnosis of HPV, and a diagnosis of HPV is incredibly common. HPV is ubiquitous. I call it, I spend a lot of time talking people off the HPV ledge because everybody's got it at some point in time in their life, okay? And it's really important to know that, but the vaccine works best when given before any sort of HPV infection. So really our focus is on younger women, but for women who are over the age of 26, there is that shared decision-making conversation. And part of that conversation has to go with, well, what was her prior risk? How well could it potentially work? What could it prevent? And most importantly, it's important to know that they still have to continue screening. We're still screening by routine guidelines, even with vaccination. The hope is the screening is going to be all negative, and we can space out the time between screens, okay? But we still need to do routine screening. With regards to payers, that gets a little complicated. It's state by state, payer by payer. In the state of New Jersey, about 90% of the payers pay for vaccination up to age 45. That's different in certain other states. And so it's definitely something that has to be discussed with the provider or with your insurance company.
Great. Mona or Kate, was there anything else that you all wanted to add with respect to that particular question?
No, just that the fact that there's an ACIP recommendation routinely through 26 and shared decision making, as Mark well explained, from 27 to 45, should allow for insurance coverage for this. But as Mark mentioned, it really varies state by state and healthcare system by healthcare system.
So Kate, I actually have a question for you based on something that Mark just mentioned, and that you did talk a little bit about, sort of the idea of stigma and feeling shame, and I think noting that, you know, HPV is incredibly common. So I wonder if you could speak to that a little bit, and what you think maybe the conversation should be around this, and what we can do both from, you know, the sort of patient perspective, but also I think from the provider perspective about reducing that stigma.
I think it's exactly what Mark said, is that everyone is going to get this. I mean, I testified on behalf of a bill a couple years ago in Massachusetts that would actually mandate the HPV vaccination for students. And I sat in a room with about 60, 70 parents that were there. I was actually one of the few people that were for the bill in the room, but I listened to all of their testimonies. It was hours and hours and hours. And through all of that, I learned that they think that if their child is getting the HPV vaccination at age 9, that means their child is having sex at 9. And number one, they thought, my child's not having sex at 9 years old, therefore they don't need the HPV vaccination. So a severe lack of education about, you know, how HPV is actually transmitted, but also these parents not understanding that, you know, a pediatrician once said this, and I thought it was so beautifully put: you put your helmet on before you ride your bike, right? Not after you've ridden the bike, not while you're riding the bike, you put it on before. So it's sort of this, we need to have the conversation. Your child will get HPV, likely. There's 80 to 90% of Americans have HPV at one point. Likely their body will clear it, but if they are one of the unfortunate people that don't, these are the types of cancers that you can get. And I think a lot of people also think this is just a women's issue. All of these people that I was listening testifying kept saying, my daughter, my daughter, my daughter. And I wanted to just scream at them, your son is at risk too, if, you know, penile, throat, and anal cancer as well. So I think that we just really need to educate about that most people will get HPV at some point. It's just a matter of when and if their body can clear it. And that this is not just a women's issue, this is an everybody's issue as well. And that the HPV vaccination is extremely safe and effective.
Yeah, thank you. As a parent of a 12-year-old and a almost 11-year-old boy and girl, I think it's really important as a parent to be able to arm myself with the right questions to ask to, you know, advocate for them. Dr. Einstein, I see that you want to answer part of this, and I would like you to.
I wanted to add to I mean, Kate's wonderful discussion about HPV. There's, you know, and Mona had mentioned this before, the strong provider recommendation is also critically important. You know, and the CDC did a lot of work on this. You know, we take a very opt-out approach. You know, today you're getting, you know, Tdap, HPV, and meningococcus. You know, not do you want it, okay? And it's a discussion. And when I talk to my pediatric colleagues who generally don't see the end results of HPV-associated disease, I like to show them pictures of what HPV does. You know, what does it look like to have cervical cancer? What does it look like to have vulvar cancer? Anal cancer is, you know, again, some of these, not only is the cancer, but the treatment can be, as Kate mentioned, very debilitating. You know, as somebody who takes care of cervical cancer patients every day, I look forward to the day that I never have to see someone suffering from cervical cancer again. And I think that our pediatric colleagues don't see those end results enough, and I think that that helps us with the strong recommendations so you do it early, because and Mona mentioned like that providers tend to delay some of that, and I think that's critical to the discussions.
Great, thank you. We have a couple of questions here. One that I really want to ask, because I think it's really important. I talked about in the beginning, and we've talked a little bit about this, right? That HPV-associated precancers and cancers, it's really multi-zonal. So although we're talking about cervical cancer because we know a lot about it, there are impacts here, right, for thinking about anal cancer, vulvar cancer, oropharyngeal, et cetera. So One question was asked about whether the vaccine protects against HPV types that are associated with anal and oropharyngeal cancers. Anybody jump in and talk more about that?
So, I mean, I could talk about that. They've been looked at for HPV load and surrogate markers in both of those cancers. We know that anal cancer, and there are particular groups of individuals that are at risk for anal cancer. Everyone's potentially at risk, but certain individuals, like individuals living with HIV, are particularly at risk for anal cancer, and there are some recommendations for more prevention. And there's been a lot of exploration of the use of the nonavalent vaccine in anal cancer prevention, and it does prevent precancers of the anus for sure. Looking at the oropharyngeal answers, it's a little difficult because there's not like a surrogate precancer of oropharyngeal cancers. And I would imagine some of the registry data is really going to come out showing just, a general decline of HPV-associated oropharyngeal cancers. I mean, the biggest risk factors for oropharyngeal cancers are smoking, and that message has to go on too. But we certainly want to, we have every reason to believe that this vaccine will also prevent against oropharyngeal cancers as well.
Mona?
Yeah, right now, this is Mona. We haven't seen any kind of trends in decrease in oropharyngeal cancers, rather just an increase. We have to keep in mind that cervical cancer right now, because of screening, is diagnosed at a much younger age. So the mean age of diagnosis for cervical cancer is much younger. So therefore, if we're going to see anything for either precancers and cancers, it's going to occur first in cervical. And since there's no precancerous stage in oropharyngeal cancer, we're going to see it later. But there's no, we don't have any doubt that we're not going to see a change. It's going to happen.
Yeah. So there's another question here that I want to maybe expand a little bit on. The question itself is, how often should women of color get pap testing? But I want to talk a little bit about some of the issues surrounding health disparities in this space, and whether there are, what can we do about improving health equity and reducing those disparities, A. There are a couple of things that I note in your presentations. One, Kate, you mentioned a couple of pieces of legislation that you thought could potentially help with that. And then I know, Mona, you were talking a little bit about some of the geographic disparities that we're seeing in rural areas versus urban areas. So if maybe we can tackle the first question first, right, about how often that pap testing should occur in women of color, and then maybe we can throw it to Kate and Mona in particular to expand on some of their thoughts on the other two issues, if that makes sense.
So, Mark? Oh, right. Oh, right. Okay. Yeah, I wasn't sure who's doing what, but this is Mona. Just right now, our guidelines are by age for cervical cancer screening. And just from the data itself, while we see higher rates of cervical cancer deaths, when we look at our data for disparities on who's getting screened and who's not, they actually show equivalency, at least for African Americans versus whites, maybe a slightly lower for Hispanics in certain populations. I really think the key is follow-up. Once there's a follow-up of an abnormal result, then there may be some, barriers that come into play in terms of whether, concerns about belief, access to care issues, et cetera. And we also have data that shows that once you look at the previous history, if a woman has been getting screened or not, her risk of developing precancers based on just the current results, if they were similar across all racial ethnic groups, would be the same regardless of race. So I think the issue is that many women may not be getting screened, and more importantly, the follow-up is a little bit different.
Okay, great. And then Kate, I know you mentioned a few things, and I did, when we chatted briefly a while ago, I had mentioned that I did want to look at some of these issues surrounding disparities, particularly in this space. So welcome your thoughts and sort of what is happening, what's the current environment in terms of working toward greater health equity here?
Yeah, I mean, I think it's examining it from the beginning. So it starts even from, clinical trials. So the legislation that I was just mentioning, the Henrietta Lacks Cancer Research Enhancement Act. Henrietta Lacks was a woman who died of cervical cancer in the 50s. And her cells were used really unethically, but still, has had some great breakthroughs in medical community because of that. But her family actually worked on a piece of legislation with the late Representative Cummings last year to decrease barriers to access of clinical trials for people. So essentially, the American Cancer Society took a look at clinical trials, and 1 in 5 clinical trials are canceled because of lack of participation. And those barriers to entry are because the clinical trials take place in places that it's too hard for them to get to. They don't have, childcare to take care of their family while they need to go to the clinical trial, the expenses and the costs associated with clinical trials. So a lot of people have to drop out of it. And unfortunately, the people that do are disproportionately people of color or people who are poor Americans or live in rural America. So so this bill, the Henrietta Lacks Cancer Research Enhancement Act, would essentially task states with assessing the barriers for people in their state and why they can't participate in these clinical trials, so that we can get more participation for everybody. It can't just be, studying white women. It needs to be to everybody, so that we can learn and enhance our treatments. So there's kind of that piece of it. And then I think to Mona's piece as well about it's the follow-up. It's the outcomes are different for people of color. Just way disproportionately because of those reasons. Because of follow-up, it's more difficult to be at the appointments when you need to maintain, home life. A lot of women in general, they're the backbone of the family. And so they put on the back burner self-care and appointments and just have to kind of keep taking care of things at home, when in fact, if we take care of women in our health, society is lifted up and does better across the board. So that's kind of where a lot of those pieces come into play.
Yeah, I mean, I think that's a good point. And that's something that we talk a lot about, obviously, at SWHR, and thinking about women as the chief medical officer of their family, but also as caregivers. And so, although I think you're absolutely right, that, your health often moves to, the bottom of the priority list. So that also actually raises another issue. So obviously, well, when we held our initial roundtable back in June, it was the very beginning of June. I think we were still at this point in time where we thought maybe we would be back to normal, soon. And obviously, here we are in November, and we're still in this, in the middle of a global health pandemic. At the time, we were asking this question and thinking about what does that mean for routine care, including vaccines, but also on that follow-up side. Is anyone seeing sort of the impact of COVID-19 on the need or women not following up on the care that they need? Has it made it more difficult? Are there things happening that could make this easier? I'm thinking particularly maybe in the self-sampling space, potentially that could help. I don't know, but that's another question that I would like to throw to you all and see about your thoughts, maybe starting with Dr. Einstein.
So, yeah, short answer is, of course. As any crisis does, it brings out the best and the worst in things. And this particular pandemic has brought out the worst side of healthcare. Some of the worst stuff includes, obviously, a lot of the medically necessary care that got deferred as a result of COVID, or as a result of people delaying their care, people that had, chest pain and stroke-related symptoms and didn't call in time. And we had a number of what potentially could be called preventable mortality during the time. There has been a tremendous amount of no-show, loss to follow-up as a result of the pandemic and just missing preventable health care. It's a double, it's a two-way street when it comes to this. There was access issues on the health system sides of things and clinic sides of things. They've had to really do everything to change their workflow to protect the healthcare individuals, to change just how they do intakes and things kind of slowed down, but also people have been reluctant to come in for their preventative maintenance and their preventative care, and reasonably so. Every healthcare system, every office, now, things are significantly better than they were during, I was on one of the frontline people. I happened to be the chief medical officer of the only public hospital in the state of New Jersey during our COVID surge. So you would imagine we went through a lot here, and we got through it, and we learned a lot. It's easy to lead when there's a plan. It's a little harder when there is no plan, and we developed the plan during the time, and we worked on that. And I could tell you that things are safer in a hospital now than they have ever been. I believe people are safer in a hospital than they are at the grocery store. And I would highly recommend getting preventative healthcare maintenance, bringing their children in for vaccination, bringing Graham in for her pap test. Do what you have to do to get that preventative healthcare.
Yeah. Absolutely. Dr. Sarai, are you all seeing anything on the public health side that you think we all need to kind of be aware of during this time? Oh.
Yeah, so I just wanted to mention first and foremost, just the first 2 days of this week, there's a president's cancer panel that will be deliberated on the impact of COVID on cancer screenings, not just cervical, but also lung, colorectal. So what came out of that meeting was really interesting in terms of it can be looked at as an opportunity to promote telemedicine when you have to prioritize, maybe even, even though cervical cancer screening might have gone down during those significantly, I think, it's an opportunity to prioritize what would be the most important when you're reopening and continuing with these different surges. And last but not least is, the role that self-collection can play and how to move that forward. So I think those are some exciting things. I think from, the vaccination has also been impacted with COVID. We've seen several CDC publications on childhood vaccinations, and therefore HPV vaccination also being impacted. So I think there's an opportunity there to see how these new innovations can be implemented with this.
Yeah. Kate, what about on the patient side? Are people reluctant and feeling like they're scared to go get, the care that they need?
Yeah, I think I was just going to say anecdotally, just a lot of people in my network are, very hesitant to go in right now. And it's just very important to hold each other accountable and to make sure that you're reaching out to all of your people and saying, have you scheduled your screenings? When's your next screening? And really making sure that the conversation is still there and you're not giving people that out, because I think a lot of people are kind of taking it right now because they're scared, and that's completely understandable. But preventing cancer is a hell of a lot better than going through it. So we really need to keep those rates going. And the momentum has been so strong. And I believe in such a bright future for research and innovation and treatments. And we have to keep that momentum going. Cancer is not going to sleep because COVID is wide awake right now.
Yeah, absolutely. I want to switch gears for a second. I have a question here. I think, Dr. Einstein, you mentioned sort of uptake in guidelines, and I know, having been at a medical professional society before, it does take quite a long time for uptake in guidelines, but anytime there's sort of new technology or new information, it can take a little while for that to either be adopted and then for the guidelines to change. So the question is a little bit technical, but the question is how to handle provider perception that cytology only is the gold standard, because that's what has been traditionally used. And this is, of course, for those who are following this space in respect to some new guidelines on HPV testing that were recently released.
Yeah, so let me address the first part of that question first, which is adoption of guidelines. I'd like to think that people that are less bald and less gray than I am are going to adopt this a little bit quicker. The general trend in learning from medical education has changed to make it not about memorizing, to really make it about adopting the information that's at hand from the patient, from the information tools and clinical decision-making tools, and from the electronic medical record, and then coming up with the right course of action and following evidence-based guidelines. And the use of evidence-based guidelines are quality measures across the board in almost everything, including cancer prevention. So I would like to think that more astute folks, that even if they are, more senior or experienced, are going to have more early adoption of stuff and not just do what they've been doing for the last 20 years because it's worked for them. So why do I have to change? All right. All these guidelines have been updated as a result of evidence-based medicine and usually very high-level data. And it's really important for physicians to sort of make that change. And I think that we're going to see that a lot more with as in medicine just in general. With regards to the second question, with regards to the shift away from cytology more to HPV-based strategies or HPV primary strategies, we know that doing cytology more frequently leads to more procedures, but does not increase the chance that we're going to pick up cancer. We know HPV-based strategies tends to be more efficient at picking up the clinically relevant cancers. And it actually decreases the amount of procedures that we might need to do to pick up that individual that might have cancer today or cancer in the very near future. So, it's really about education, I feel. I think that we have to really do our best to get the word out there through forums like this, through educating folks in DC, through educating our local health legislators, local community advisors, and others about what is the role of prevention, what is the role of the PAP. And we certainly don't want to, we're not dismissing the PAP in any way. There's elements of PAP in almost everything that we do now for cervical cancer screening, but we are drifting to these more sensitive types of technologies right now.
Great. There's another question here, and I, of course, can't just ask the one question because it brings up another question for me. I'm going to start with a question that's here, and then I'm going to come back to my follow-up. So the question is, what messaging do we need to use to ensure that women understand what screenings they need? They go on to say so many gynecologists give annual PAPs or no HPV testing, et cetera, which don't necessarily reflect guidelines and can end up confusing women about what they need, and there seems to be a disconnect. So this person is asking, how can we do better, especially from the patient advocacy perspective?
Well, I would hope we're moving away from annual PAPs. That we took out of the guidelines over 10 years ago. So, I would hope that sort of trend has moved away. What sometimes happens, though, people have what I call insurance migration, where they might have this insurance and then, different employer, or they lose their insurance and they have to go on a different plan, and then they have to go see a different provider, and they don't have all, and then sometimes they just get another PAP. Sometimes it's just, and that disjointedness is actually, unfortunately, quite common in the United States, and that sometimes leads to things, especially in young women, who often, are underinsured, frankly. So that's something that needs to, to some extent be resolved. I think part of the accommodations of ACA plans is the provision of preventative services is critical, and that is a critical part of ACA that hope we expect to continue in the near future. And as a result of that, this will hopefully help to decrease the Swiss cheese effect of what could happen without the appropriate preventative care.
Just wanted to confirm there is less annual testing going on according to most national data.
Okay.
Good sign.
Kate, do you have thoughts on this question?
I was just going to say it's raising awareness about what HPV is. I was just amazed at even when I was diagnosed, I knew that I got it because of HPV, but I didn't really understand what my risk factors were when I was diagnosed with HPV. It's just so much more education about HPV that needs to kind of happen from the beginning. And I think women need to walk into those appointments with their doctors armed with better questions to advocate for themselves, because, and it's just a matter of being more aware, and we have to kind of even just change our curriculum around women's health and make sure that we're more empowered with this information. I didn't know much about HPV at all, in college, and I really needed to.
Yeah, actually that is a perfect segue into my follow-up question to this, which is, we've talked a lot about sort of obviously because we've been talking a lot about cervical cancer, the role of the gynecologist and sort of that sort of path of care. When we think about the other types of HPV-associated precancers and cancers or other related disease, who owns the patient? And I ask this, and you're not, where would you maybe want to ask these questions if maybe you're not there to see your gynecologist? And Michelle Longabaugh, who I mentioned at the beginning of this program, as an anal cancer, patient, had said that she went to her primary care physician. She was in Kansas. It took her a long time to figure out kind of what was going on. At the end of the day, it was her gynecologist who ended up diagnosing her. So are there different aspects of the clinician education beyond sort of the gynecologic perspective that we need to be thinking about? And what might that look like in addition to that question of how do we as women arm ourselves with the right questions and understanding of what does this mean? And I often think too, right? Like you're told, okay, well, I've got the vaccine. This is not a problem. Like what are the, or you didn't get it. And so go talk to whoever your healthcare provider is. So I think there's a couple of different approaches there. But first of all, thinking on the clinician side, perhaps like who are the care partners that patients might want to ask this question of in addition to their gynecologist?
So I'd like to take, first of all, it's not, as I always tell my colleagues in primary care, I'm here to manage when the PAP is abnormal. I'm not here to do the PAP. We're all here to do the PAP. Just like when a woman sees me who's of age for a mammogram, I order the mammogram. If she needs a colonoscopy, I order the colonoscopy. It's my job to help maintain the preventative health maintenance and not have those missed opportunities for prevention. So the owning space is a lot of disciplines: primary care, family practice, our advanced practice clinicians, APNs and PAs do a lot of the primary care screening in rural areas in the United States, and our midwives, and it's critically important to include them in that discussion. With regards to the other cancers that you brought up, as much as we'd like to strive to work to screening, we don't have screening right now for head and neck cancers. There's no approved screening. And with regards to anal cancer screening, there have been some, like New York State HIV, Department of HIV and HIV-related medicines, as well as the VA, have advocated for anal cancer screening in the setting of individuals living with HIV. But other than that, we don't routinely screen people for anal cancer. But if somebody is at risk, meaning that they've had some dysplasias of like the vulva or vagina, we would have that shared decision-making conversations to individualize management of that patient.
Great, thank you.
Yeah, and the only thing I would add is just for women, it's just knowing our bodies, in and out. My biggest flag that I raised to my OB, which is what propelled her to get the colposcopy, was I started to have bleeding after intercourse, and that had never happened to me before. And I think a lot of women, these things happen to us, and we just think, oh, that was a fluke, And so it's so important to know your body well enough to say, nope, this is not right. This is not what my body does, and flag it to kind of the necessary people. So I think the accountability about your own health really needs to be a conversation as well.
Okay, great. So we have.
I was just going to add that primary care providers outside of OBGYNs do play a big role. And I think with the advent of these clinical decision-making tools that Mark spoke about, we can potentially improve referral that way. Like some of the low risk where there's observation occurring, not necessarily like immediately, refer them to the OBGYN. It's possible to do that. And I think there have been systems like Mayo Health Clinic systems that have been really able to improve that, because there's a lot of regions in the United States that do not have enough OBGYNs or any OBGYNs to manage this. So I think we need to really take advantage of all the people who are doing clinical care for women.
Great. So we have just a couple of minutes left. I want to give you each, a minute or so to sort of give us your final thoughts. If there's one thing that you want folks to take away from today, what would that be? And we'll go the opposite direction in which we started. So we'll start with Dr. Einstein, then Dr. Soraya, and Kate.
So I really want to thank all of you for coming, and I hope you've gotten something out of this. I feel that all of you are part of the Coalition of the Willing and the armies to be able to spread that education to your communities, to your neighbors, to your mom, grandma, aunt, daughter, everyone that needs to get it. Again, as somebody who takes care of women with cervical cancer, this is, with primary prevention with vaccines and routine screening and appropriate education and not missed opportunities, it's preventable. And I look forward to the day that we can eliminate cervical cancer. And I think with all the efforts of the Coalition of the Willing, we really can get to that point. I'm hoping while I am still in practice.
Thank you. Dr. Soraya?
I was going to say a lot of the things that Mark had mentioned, but cervical cancer is preventable. As I mentioned, a lot of screening, a lot of women currently in the United States are not getting screened. And these might be women, immigrant women, women without access insurance. So we need to consider that. And the best test that gets done is the one that gets done at the longest interval possible. And looking forward for the initiative, the cervical cancer initiative coming out by the WHO to eliminate cervical cancer as a public health problem. I think we've seen from the modelers here in the United States that with vaccination, we're going to reach this, but if we improve screening, we can get there a lot faster.
Excellent.
And I would just add, talk about it, talk about it, talk about it, talk to everybody about it. January is Cervical Cancer Awareness Month. I think cervical cancer is one of those that it doesn't have as much of a face as a lot of other cancers do. Use it as a reason to email 60 women in your life and say, when is your next screening, or are you up to date with your screenings? It's so important that we hold each other to it, and you just talk about it, even to people who may get a little squeamish when you're talking about HPV and your cervix. It's really important to do so, and find resources. If you're not comfortable, direct them to resources where they can learn about it in the comfort of their own home.
Great. Thank you so much, everyone. There are a few common themes, of course, as we're thinking about this, thinking about how we empower ourselves with the care of our family, just to echo exactly what you said, Kate, right? Keep talking about it. Whether you're talking about this from the perspective of cervical cancer or the other cancers that may ensue from HPV. I think the other piece obviously is related to sort of the public health perspective and ensuring uptake in vaccination and screening efforts, as well as clinician education, and continuing to ensure that we're keeping up with innovation as much as we can. I think we had some really great questions. We didn't quite get to some of the more policy oriented issues that I think we thought maybe we would get to, but I wanted to make sure we answered audience questions. I would say from our perspective here at SWHR, and in thinking about sort of what that means for coverage and access and inclusion in clinical research, and pushing for additional investment in research and those sorts of things. We're very committed and dedicated to that. And I think there's a lot of opportunities there for this Coalition of the Willing to, as Dr. Einstein said, to really come together and advocate both for ourselves, our families, et cetera. So thank you all for joining us today. Thank you for your time and your insight. And also another huge thanks to our sponsor, Inovio, without whom we would not be able to host this event. The one last plug I need to make sure that I give to everyone is that I'd like to invite you all to SWHR's next webinar, which will talk about wellness strategies for people living with migraine disease to improve their quality of life. That is scheduled for December 10th at 1 p.m. Eastern. And you'll hear from our migraine experts and patient advocates in that space. Again, we will share the recording and continue to share information as much as we can to further facilitate this conversation and make change. So thank you all very much.